Welcome back to Ellie Scrubs In, where we make surgical training visual, practical, and memorable. You're watching part 6 of our surgical instrument guide, and today's episode is a special one, a bonus video all about laparoscopic instruments. Minimally invasive surgery has revolutionized the way we operate. Instead of large incisions, we now use tiny ports, slim tools, and sophisticated energy devices to perform procedures with less pain, faster recovery, and fewer complications. But mastering laparoscopic surgery means understanding a whole new set of instruments, many of which look nothing like their open surgery counterparts. In this episode, we'll walk through 6 basic yet essential laparoscopic instruments, from access devices and visualization tools to graspers and scissors. These are the tools you'll see again and again in laparoscopic procedures and even robot-assisted surgery. Whether you're a med student, scrub tech, resident, or just laparoscopically curious, this guide will help you recognize, understand, and confidently work with these core tools. Let's scrub in. Before any laparoscopic surgery begins, the operating team must first create a safe and functional working space inside the patient's abdomen. This starts with the insertion of a Veress needle, a spring-loaded device used to gently enter the peritoneal cavity. Once proper placement is confirmed, carbon dioxide gas is insufflated to expand the abdominal cavity, creating what's known as a pneumoperitoneum. This inflated space gives the surgeon room to see and work. A trocar and cannula system is then inserted to provide access ports for instruments. Through one of these ports, a laparoscope, a thin, high-resolution camera, is introduced and connected to a monitor, turning the operative field into a video-guided environment. Additional ports are placed under direct visualization, and the surgeon and assistant operate using long, slender instruments while watching the procedure on the screen. The setup requires coordination, stable insufflation, a clear view, and careful port placement, all of which are essential before the first cut is ever made. Veress Needle. The Veress Needle is the very first instrument used in many laparoscopic surgeries. It's a spring-loaded needle designed to safely create a pneumoperitoneum. That's a gas-filled space inside the abdomen, using carbon dioxide. Structurally, the Veress needle looks like a long metal tube with a sharp outer needle and a blunt inner stylet. When you press the Veress through the abdominal wall, the sharp tip pierces through layers like skin, fascia, and peritoneum. Once inside the open cavity, the inner blunt stylet springs forward to protect the sharp tip, helping prevent accidental puncture of bowel, vessels, or solid organs. Once properly placed, the Veress needle connects to the insufflation tubing, which delivers carbon dioxide gas to expand the peritoneal cavity. This creates working space and lifts the abdominal wall away from internal organs, making room for safe insertion of the trocars and instruments to follow. Surgeons often use the saline drop test to confirm correct placement. They place a drop of sterile saline at the hub of the needle and watch for it to suck inward, indicating negative pressure inside the peritoneal space. Alternatively, some setups use a pressure-sensing insufflator that gives real-time feedback. If the pressure is too high at the start, it's likely the needle is in the wrong plane, maybe the pre-peritoneal space, or even inside an organ. In that case, the needle is removed and another attempt is made. Blindly inflating the wrong space is a recipe for disaster. The Veress needle is usually inserted at the umbilicus, where the abdominal wall is thinnest, but alternative entry sites include Palmer's Point in the left upper quadrant, especially in patients with prior surgeries or suspected adhesions. Always confirm your position before insufflation. A misplaced Veress needle can fill the retroperitoneum, bowel wall, or vasculature with carbon dioxide, which can cause severe complications or even gas embolism. Use the saline drop test, pressure readings, or ultrasound guidance in high-risk cases. Hit fall. Pushing too hard or at the wrong angle can puncture bowel, bladder, or major vessels, especially in thin patients or those with adhesions. If you're unsure, switch to an open Hassan technique instead. Laparoscopic trocar and cannula. Once the abdomen is insufflated, the next step is gaining access, and that's where the trocar and cannula system comes in. These devices are the gateways through which all laparoscopic instruments are introduced. A trocar is the pointed instrument, sometimes sharp, sometimes blunt or conical, that punctures the abdominal wall. The cannula, also known as the port, is the hollow sleeve that stays in place after the trocar is removed. It creates a channel between the outside world and the insufflated peritoneal cavity, maintaining the pneumoperitoneum. Trocars come in various diameters, with the most common being 5, 10, and 12 millimeters. Each size corresponds to the instruments that will be passed through it. For example, most graspers and scissors are 5 millimeters, while clip appliers or cameras usually need 10 or 12 millimeter ports. Cannulas also come with or without valves. A valve at the top allows you to pass instruments without losing gas pressure. Some even include stopcocks for insufflation tubing or conversion ports to downsize to smaller instruments. There are 3 main trocar tip designs. Bladed trocars, these have a sharp edge for cutting through tissue. They allow easier entry, but come with a higher risk of injury to internal structures. Bladeless trocars, these use a cone-shaped tip that stretches tissue apart rather than cutting. Optical trocars, these allow a laparoscope to be placed inside the trocar, giving real-time visual feedback as the surgeon advances through the abdominal wall. The initial trocar, usually placed at the umbilicus, is the most dangerous, because the surgeon is blind or semi-blind to what lies beneath. That's why technique, positioning, and tactile feedback matters so much. Secondary trocars are placed under direct vision, often at the right upper quadrant or suprapubic region, depending on the case. Insertion requires steady, controlled pressure, not brute force. Surgeons often make a small skin incision first to allow passage, and may use a twisting motion to advance through the muscle layers and peritoneum. A sudden pop indicates entry into the cavity. Once the trocar is in, the inner obturator is removed, leaving only the cannula behind, ready for instruments to be introduced. Pearl. Match your port sizes to your case. Don't open a 12 millimeter port if you're only using 5 millimeters instruments. Larger ports are more painful post-op and carry a higher risk of hernia. And always check that your cannula valves are intact before starting the case. A broken valve leads to constant gas leaks and poor visibility. Pitfall. The biggest danger is unintentional injury on insertion. This is why careful insufflation, midline insertion, and anatomical awareness are crucial. Improper angling can lead you into the preperitoneal space, not the cavity itself. You'll notice resistance or poor visualization afterward. Laparoscope. The laparoscope is the surgeon's eyes inside the abdomen, and without it, laparoscopic surgery simply wouldn't be possible. It's a slender, tubular camera that transmits real-time video from inside the body to a high-definition monitor, giving the surgical team a magnified, illuminated, and panoramic view of the operative field. Laparoscopes come in 2 common diameters, 5 and 10 millimeter. The 10 millimeter scope provides superior optics and light transmission, making it the standard for most general surgeries. The 5 millimeter version is slimmer and less invasive, but offers slightly lower image quality, better suited for pediatric cases or secondary ports where space is tight. But the real secret weapon of the laparoscope is its angle. The lens at the tip comes in different viewing angles. The most common are 0, 30, and 45 degrees. A 0-degree laparoscope gives a straight-ahead view. It's intuitive but limited in flexibility. A 30-degree scope is by far the most versatile. It lets you look around corners, under organs, and even back at your ports with a simple rotation. The 45-degree scope, while less common, is useful for certain pelvic or retroperitoneal procedures where extreme angulation is helpful. Most laparoscopes are rigid, meaning they don't bend, and are connected via fiber optic cables to an external light source and a camera head. Some systems use digital chips built directly into the tip for even clearer imaging. These are called chip-on-tip scopes. To keep your view clear, laparoscopes have a flush port that can be connected to a saline or warm water system. This allows the surgeon to clean the lens mid-case without removing the instrument, especially useful when condensation, blood, or tissue fogs the optics. Before the scope even enters the body, prep is critical. Fogging is a common problem, and it's preventable. You can use anti-fog solutions like FRED, Film Residue Eliminator for devices, Pre-warm the scope tip using a warming tray or by dipping it into warm saline, or gently wipe it with a lint-free sponge moistened with solution right before insertion. The laparoscope is usually introduced through the umbilical port, which is anatomically central and hidden cosmetically. The camera operator, often a surgical assistant or resident, needs to maintain a steady hand and coordinate closely with the surgeon. Good camera technique means anticipating the next move, holding a stable horizon, and minimizing unnecessary motion. The term camera choreography refers to the silent communication between surgeon and camera holder. Smooth collaboration improves operative flow, reduces time, and prevents accidents. Pearl. Mastering the laparoscope is an art. The scope operator should always keep the target in the center of the field, maintain the correct horizon, no tilted angles unless intended, and avoid frequent scope removal, which breaks focus and wastes time. A great camera assistant makes surgery faster, safer, and smoother. Pitfall. A dirty, fogged, or improperly focused scope can stall the entire case. If the view is poor, stop and fix it. Don't try to operate blind. Also, never use abrasive materials to clean the lens. Scratching it permanently degrades the image. And remember, the scope is delicate and expensive. Dropping it or mishandling during transport can crack the lens or damage the internal optics, rendering it unusable for the rest of the day. Laparoscopic grasper. The laparoscopic grasper is one of the most frequently used instruments in minimally invasive surgery, and it comes in more variations than almost any other tool in the laparoscopic tray. Its primary job is to manipulate, retract, and mobilize tissue inside the abdomen, and it must do all of that through a long, narrow shaft under video guidance with zero tactile feedback. Graspers come in atraumatic and traumatic varieties. Atraumatic graspers are smooth, rounded, and designed to minimize damage while still providing enough grip. They're used for handling delicate tissues like small bowel, omentum, gallbladder, or fallopian tubes. The jaws may be fenestrated, meaning they have holes to reduce pressure on the tissue while still providing grip, or fully smooth, depending on the manufacturer. Traumatic graspers, on the other hand, are more aggressive. They often have teeth or ridged serrations, and are used when firm grip is necessary, such as grasping fascia, thick adhesions, or holding on to tissue that will be resected. One commonly used variant is the rat tooth or alligator grasper, which has pointed or serrated jaws that offer aggressive purchase on tissue, but at the cost of potential trauma. For delicate work, such as in pelvic procedures, dolphin nose or Babcock graspers are preferred. Most graspers are controlled by a ratcheted or non-ratcheted pistol grip at the proximal end. Ratcheted handles allow the surgeon to lock the grasper in place, holding tissue without continuous squeezing. This is useful when holding tissue out of the way for an extended period. Some graspers also include rotating shafts, allowing the jaws to spin without rotating the entire instrument. This feature improves ergonomics and access to tight angles, especially when working around curves or corners, such as in the deep pelvis. Graspers are extensions of the surgeon's fingertips. Learn to use visual cues to assess tension and pressure. If tissue starts to blanch or slip, you're either pressing too hard or not enough. Mastery of the grasper means gentle, controlled movements that preserve tissue integrity. The biggest danger with laparoscopic graspers is crush injury to delicate structures. In minimally invasive surgery, it's easy to overestimate how much pressure you're applying. Always watch the tissue for signs of stress. If the grasper is dimpling, tearing, or leaving impressions, back off. And never use traumatic graspers on hollow organs like bowel or ureter. A single misstep can lead to delayed perforation or stricture. Laparoscopic scissors. Laparoscopic scissors are among the most essential cutting tools in minimally invasive surgery. They are long-shafted, fine-tipped instruments designed to fit through small ports and provide clean, precise cuts inside the abdominal cavity. These scissors are used for sharp dissection, tissue division, adhesiolysis, suture trimming, and more, depending on the blade configuration and whether they carry energy. There are two main categories: mechanical, or cold scissors, and electrosurgical, or hot scissors. Mechanical scissors simply cut tissue, like regular scissors, while electrosurgical scissors are often monopolar capable, meaning they can simultaneously cut and coagulate tissue when connected to an energy source. Most laparoscopic scissors have curved blades, though straight versions exist. Curved scissors allow better maneuverability and visualization around structures, especially when dissecting in tight planes or corners. The handle mechanism typically features a ratcheted or spring-loaded grip, and many scissors have rotating shafts, allowing the surgeon to twist the orientation of the blades without rotating their wrist or the entire instrument, a key ergonomic advantage in laparoscopic work. Common subtypes include Metzenbaum-style laparoscopic scissors for fine dissection of soft tissues, hook scissors with a sharp hook tip, ideal for precise snipping in fibrotic or vascular tissue planes, and endoscopic scissors with monopolar capabilities, designed to deliver cautery through the blades during cutting. When using monopolar scissors, one blade becomes the active electrode, delivering electrical current as the surgeon activates the foot pedal. This allows simultaneous cutting and coagulation, which is helpful in bleeding tissue. However, it also introduces risk. Thermal spread can damage adjacent structures, like ureter, bowel, or vasculature. By contrast, cold scissors offer tactile precision without energy, but require excellent hemostasis and more deliberate technique. Cold dissection is often preferred in delicate areas such as near the bile duct or ureters. A major skill in laparoscopic surgery is learning to cut without excessive traction or energy use. Precision is everything, both in what you're cutting and how you're holding the instrument. Pearl. Use curved laparoscopic scissors for fine, controlled dissection in fibrous planes. They provide better angle of approach and reduce torque. Keep your cuts slow, deliberate, and always under direct vision. Pitfall. Never activate monopolar scissors near metallic clips, trocars, or other instruments. The current can arc and cause severe internal burns. Likewise, never use laparoscopic scissors as a grasper. It dulls the blades and increases risk of accidental cutting. Always switch tools if you need to manipulate tissue. Maryland Dissector. The Maryland Dissector is a versatile, curved jaw laparoscopic instrument used for fine dissection, tissue manipulation, and vessel isolation. It's one of the most commonly used tools in laparoscopic surgery, and is often favored by surgeons for its ability to tease apart tissue planes, elevate structures, and even apply energy, depending on the version. Its design, combining a slim profile, angled tip, and precise jaws, allows the Maryland to function as both a dissector and, in some cases, a grasper or coagulator, making it a true multi-tool in the laparoscopic tray. The Maryland has a pair of narrow, curved jaws, typically with fine longitudinal serrations along the inner surface. This jaw curvature allows the surgeon to reach around vessels or ducts, or to approach angles that would be difficult with a straight instrument. The shaft is long and rigid, suitable for use through 5 or 10 millimeter trocars, and most Maryland dissectors include a rotating knob near the handle, so the jaws can be twisted for optimal positioning without rotating the entire instrument or the surgeon's wrist. This helps with ergonomics and precision during fine dissection. The handle is usually pistol grip or ratcheted, and many Maryland dissectors are monopolar compatible, meaning they can deliver electrosurgical energy for cutting and coagulation. Dissection with the Maryland is generally blunt and progressive, meaning the surgeon spreads the jaws gently to separate tissues, rather than cutting directly through them. This helps maintain hemostasis and preserve surrounding structures. Some surgeons also use the Maryland for push and peel techniques, using the closed jaws to push through a tissue plane, then spread them gently to open up a safe dissection layer. When monopolar energy is applied, it can coagulate small vessels as they are divided, though care must be taken to avoid unintended thermal injury. One of the key advantages of the Maryland is its ability to both dissect and grasp, allowing the surgeon to explore, isolate, then elevate or retract tissue, all with one tool. Use the Maryland dissector to develop safe planes around critical structures like the cystic duct, ureter, or mesenteric vessels. The curved jaws give you both access and visibility. When connected to monopolar energy, it becomes a precise cautery tool. Just be mindful of thermal spread. Pitfall. Avoid using the Maryland for heavy pulling or retracting thick tissue. This can damage the tip, degrade the fine serrations, and reduce precision. Likewise, never activate energy near sensitive structures like bowel or nerves unless you have clear separation and excellent visualization. And that wraps up part 1 of our laparoscopic instrument guide. From the Veress Needle to the Maryland Dissector, these tools form the core of every minimally invasive procedure. Understanding how they work and how they're used sets you up for success in the OR. In part 2, we'll explore advanced tools like clip appliers, suction irrigators, and energy devices. So hit that subscribe button, turn on notifications, and scrub back in with us for the next video.